This CT scan in both the axial and the coronal sections demonstrates the presence of mid-layer disease in the mastoid on the right side, and one can also notice the presence of a lateral semicircular canal fistula by seeing the breach in bony margins of the soft tissue in the mastoid in the antrum region and the lateral semicircular canal. This patient presented in the emergency with a previous history of ear discharge lasting years, coupled with recent acute onset of vertigo for the past few days, and coupled with severe progressive hearing loss in the similar duration of past few days as well. On examination, one could see a large central perforation, but on endoscopic examination, the presence of an attic pathology was duly noted. A CT scan, a non-contrast high-resolution CT, shows the presence of mastoid disease with the presence of a lateral canal fistula. And the plan here is to do a canal wall down mastoidectomy. There is already a severe hearing loss on the affected side, with the other ear being normal. So we are going to go ahead with the canal wall down mastoidectomy in this case with a standard post-oral approach. As you see, we have placed a shield cover for the protection of the tympanomeatal flap so that it does not get injured in the drill use. And here we are doing an inside-out approach. And even in inside out, it doesn't mean we start drilling in the attic, but when we know that we have to go for a canal wall down surgery, we begin with the generous canalplasty, drilling off the superior wall and the posterior wall, creating a small cavity at the outset so as to create space for our drill to go inside. Once that is done, the drilling will proceed from an atticotomy and will progress backwards following the tegment plate into the antrum and thus create a mastoid cavity. This ways, we limit the size of mastoid cavity by following the disease in sclerosed mastoids. In sclerosed mastoids, this technique is very handy, and it is generally by default our technique of choice in sclerosed mastoids while encountering cholesteatoma, where our decision to take the canal wall down has been made preoperatively. As you see here now, we are drilling the attic shelf, the scutum bone, which is often eroded in these patients. It is important and imperative to use the right sized burr. A very large size or a very small sized burrs, both would be non-beneficial, in fact harmful in these patients. A small sized burr can slip inside or pierce the tegmen or the ossicles, and too much of a large sized burr, especially a cutting burr, will cause collateral damage on the blind side, which is not visible while drilling. So relatively small to a medium-sized cutting burr is used for the initial steps. Our goal here is not to create a very big cavity. So we are limiting the drilling initially medially to see what are the limits of the cholesteatoma. And thus we would keep on enlarging this cavity on a need-based situation. You can already see the cholesteatoma flakes in the shadow of the epithelium coming on as we drill the attic further and further. And it is not surprising to see even small cholesteatomas sometimes leading to labyrinthine fistulas and causing permanent hearing loss. As you see here, the cavity has been enlarged and the mastoid cavity has been incorporated into the atticotomy and the antrostomy. So you see now we are focusing on the posterior and the lateral wall, and you can see the diseased epithelium and the diseased mucosa, which is removed using a large blunt elevator. It is a usual practice to send this edematous mucosa both for histopathology as well as for tissue cultures, because often these patients have been on antibiotics and pus cultures alone may not reveal the offending organism. Finding the right organism and the right antibiotic sensitivity goes a long way in ensuring optimal outcomes in these patients. So part of the tissue goes for histopathology, part of it goes for tissue culture, and that is separate from the actual cholesteatoma sac that we remove. Though we know it's a cholesteatoma sac, it's still a good practice to send for histopathology, but we also make a point to send some granulations and the diseased mucosa just in case one accidentally encounters a granulomatous disease of some kind. So once the tegment plate has been cleared, now we are clearing this diseased mucosa or granulations at the level of the lateral canal. Now, as you can see, now already since this patient has had a severe sort of a hearing loss, hearing right now is not of a much concern here. It's already a non-serviceable ear with the opposite ear being totally disease-free. So we can take our liberty in disease clearance in such patients without worrying too much about the hearing. You can see the incus body, which is lying loose and is being separated from the epithelium. Of course, this will be discarded. So in these situations, one always has to understand and appreciate that disease would be epicentered around the second genu of the facial nerve, around on the ossicular region and on the labyrinth. So once your bony exposure has been broadly made, attention to detail is paramount while clearing disease from these vital areas. Also, a bone of contention always is the anterior epitympanic space, which we see very often not being opened adequately and thus always becomes a hidden point in the postoperative periods, thus leading to recurrent cholesteatoma. So it's very, very important and it's imperative to open the anterior epitympanic recess widely in all canal wall down mastoidectomy cases. Without that, the surgery is really not complete. So we are clearing off now the malleus head, the remnant of it. You can see it's already eroded. The incus was already removed. Now here we side by side start doing the lowering of the facial ridge as we saucerize this cavity. And apart from lowering, what we also strongly recommend is the thinning of the facial ridge. And it is always thinned on the anterior aspect, not preferably on the posterior aspect, because we want it broad, we want it smooth. But for the appropriate clearance of the posterior mesotympanic recesses, the sinus tympani, we want to be clearing, uh, thinning this facial ridge anteriorly, that is basically the posterior canal wall lateral to the posterior mesotympanic recesses, so as to get as much a broad view of the posterior mesotympanic recesses and the sinus tympani as much as possible, which is often the site for disease in these patients. Once we do that, we proceed to drilling of the anterior epitympanic recess. Like I said, it's very important to drill it widely, open it for comfortable suction toilet in the post-operative period. And at the same time, we keep saucerizing the cavity, we keep lowering the facial ridge. These steps are often better done as together rather than doing it separately at the end of the procedure, because once you do an ample saucerization, it also gives you a far better vision and instrumentation space inside the middle ear cleft. We can see now how progressively we clear the disease over the epicentered area, which is the site of the lateral canal, the posterior epitympanum. And I normally prefer to use sharp dissection in this place rather than blunt dissection, because with sharp dissection, one knows, and the traction on the medial aspect, which could be a dehiscent facial nerve, is far more controlled as compared to pure blunt dissection. The choice of suction is very important. Use generally a blunt suction, a thin suction, and to maintain optimal vision, one of the assistants can continue to irrigate gently, drop by drop, so as to maintain a clear vision and not having a field which is soaked in blood. So very often it is not too difficult to raise the epithelium over the lateral fistula, especially if it is a very small one. It comes off in one piece like it is in this case. You don't see any epithelium. Whereas the most of the times the toughest part is over the stapes, and like such, you can see how the epithelium is engulfing the stapes head. And though in patients where hearing is intact, one should try to minimize the stapes movement as much as possible. In patients with severe or profound deafness, one could either ablate the stapes using a carbon dioxide laser, or sometimes even resect the stapes using sharp instrumentation. But often we do not want to contaminate the inner ear still with the diseased mucosa or the epithelium. So, as a primary surgery, all effort must be made to clear the disease from this intact stapes. Here, as you can see, we have resorted to the thinnest suction possible, akin to what we use in stapes surgery. A size 23 or a 24 would be useful here. We can see the processus cochleariformis right in front of us, the stapes below it, and how using a constant minimal suction and a sharp sickle knife or a needle is important in completely elevating the diseased epithelium from the stapes. You do not want to be leaving any epithelium here, and you do not want any recurrence of disease, especially given the fact that the patient already has close to a non-usable ear. So I think radicality here is important in ensuring disease clearance. If for some reason one feels that it is impossible to clear disease from this, I don't think one should shy away from resecting the stapes while preserving the footplate using a sharp scissors. You can see we are also trying to be sure that all epithelium over the processus cochleariformis and the facial nerve region is also completely removed and not present anymore. The anterior epitympanic recess is now broadly and widely open. And now what you see is here is the malleus head, on which there is still some epithelium remnant, which we intend to clear after resecting the malleus handle, not head, handle, from the processus cochleariformis by sectioning the tensor tympani tendon. As you do so, you see also some small sacs of epithelium that lie hidden and buried in the anterior epitympanic recess and the protympanic region. And one should appreciate how important it is to broadly open this area, because sometimes uh, enough disease clearance from the rest of the area but not clearing the anterior epitympanic recess can lead to grossly missing of disease, which would obviously come back with a recurrence. That would be unfortunate. You can see how a small epithelial pearl is lying hidden inside the anterior epitympanic recess, and why it is so important to open this area and, as a process, search for disease here and not just imagine or hope that there's nothing here. Once again, using a sharp dissection comes of a huge value in this part of the surgery, rather than using merely a blunt elevator, which often may either rupture the sac and may lead to the diseased epithelium or the cholesteatoma or the squamous debris behind in this part, which could be a difficult region to track even in the post-operative period. Very often we see that this is a lot of obsession, so to say, with the bony work in mastoids. And while that is important, equally or more important is the soft tissue work. And in case the soft tissue work is incomplete, it often leads to poor outcomes after mastoid surgery, whether it is intact wall or canal wall down. And just by doing a canal wall down, one doesn't get to miss the soft tissue work that should be done adequately to give these patients a disease-free year. So even if there is some doubt about some mucosa being diseased grossly, I think that should be resected. It is, after all, a non-serviceable ear. And here as well, we prefer to sharply dissect structures rather than bluntly pulling, and because that would devitalize the mucosa or strip the middle layer of the mucosa. So it's generally not a good idea, even though this patient has a considerable hearing loss. And once the anterior epitympanic recess and the protympanum are cleared, we get our attention and focus back on the stapes head. And what we see is that our vision posteriorly of the sinus tympani region is still limited and because of the bone. So now we resort to drilling of this bone further using a 2 mm diamond burr to be able to obtain a better vision in this part of the mesotympanum for optimal disease clearance. So adequate irrigation is important in this step. You don't want to be overheating, but you also don't want to flood the middle layer or the surgical cavity, because then that would limit your vision. Using a small diamond burr in this situation, and once your exposure is serially or progressively increased, you come back again on clearance of disease from the stapes head till the time you start seeing bare bone on the stapes head and the superstructure. So we're using here a very fine, microfine crocodile forceps, especially used for this purpose, because we do not want to be using a larger cup forceps, because that has the potential to pluck out the whole stapes, even with the fraction of millimeter misaccuracy on the stapes head. So the point is just to pluck out the finest part of epithelium, which you find it difficult to come in the suction. So once that has been done, we again resort to opening the anterior epitympanic recess slightly more widely, because we want the cavity to be saucerized. So now for this part, we use a large diamond burr to saucerize the cavity, while also keeping a clear focus of the fact that we do not want a very large cavity, but good saucerization helps in reduction of the overall cavity size, because it lets the soft tissue of the post-auricular region fall inside with relative ease as compared to a standing tall mastoid cavity. Diamond burr also helps in achieving hemostasis over this region. As we come under a lower magnification, we can see how the mastoid cavity looks. It's a fairly small cavity. It's not a big cavity with the ridge lowered adequately. And some bit of this posterior part of the cavity we will obliterate, either using cartilage or the periosteal flaps, so that the final cavity is even smaller. Once again, it's very important to also clear off disease and drill all the irregularities as much as possible. Remove any buried mucosa wherever you can see it to completely clear the disease, because as much as the bone is clean, you don't have mucosal weeping, and these cavities heal very well in the post-operative time. You can see how now we are using conchal cartilage to obliterate the posterior and the inferior part of the cavity. So we use conchal cartilage full thickness. We can use 1, 2, or 3 portions depending on whatever we retrieve from the concha. If it is less, we can also use some from the tragus, but here we are just using conchal cartilage. And once we have obliterated the middle ear space a little bit and the posterior posterior inferior mastoid space, we augment this with the temporalis fascia graft, over which we replace our tympanomeatal flap. And that leads to a fairly small mastoid cavity, which should be hopefully easy to manage in the post-operative period. The anterior cartilage graft has already partially obliterated,